My name's Zara Gandon. I'm a GP in Stoke and do a lot of diabetes and obesity care, and so have been quite interested in how we're going to deliver Mounjaro in the community, and have been doing some Mounjaro prescribing for over a year now in a different context. So hopefully today I can just share with you some of the things that we have done that might help you. First of all, I just really want to acknowledge the political landscape here. This is a really complex area. It is. I agree that it should never have gone into QOF, and I understand the stance of GPC England and the LMC in advising practices not to do this. We have as a practice decided to do it, but I do stand with the argument that it should never have gone into QOF in the first place. So part of the reason, one of the arguments for not going into QOF is that QOF is about work done, but the other argument is also to do with just the level of payment that's associated with this. How do we do good clinical care under a very strict budget? So I would just like to share with you what we're doing as a practice to try and facilitate good, safe clinical care in a concise, efficient way. So what we're doing, this is just a slideshow to show you what we are doing as a practice. First of all, one of us partners, as me, will look at the patients that you can find either in the obesity cohort on QOF, or also there are the ICB searches. I'm just going through those patients, checking that they haven't got a history of pancreatitis or medullary thyroid carcinoma and exempting them. And then also checking whether they've got gallstones, having not had a cholecystectomy. If they have got gallstones, then I'm asking them if they're interested in Mounjaro, and if they are, I'm doing this all by text, if they are interested, letting them know that they'd have to have their gallbladder out first and checking they're still interested. Also, if you've got diabetics, you need to check that the level of their retinopathy, because if you drop a patient's HbA1c too quickly, when they've got advanced retinopathy, you can actually make their retinopathy worse. So I've looked first of all at the patients who've got the cohort 1 patients that weren't dealt with last year, and those in cohort 2 with the highest BMI and or 5 out of 5 of the criteria. I then inviting via text 15 patients in, making it very clear on the invitation that I'm inviting them to a group consult. It says, you are eligible for tirzepatide, the weight loss drug. If you'd like to come and hear more in a group consultation, click that you're interested below. When they come back to me, say they're eligible, we then invite them in. We did our first one about a month ago. Invite 15 with the aim for 10. So we've got a larger meeting room upstairs that we're inviting them to come into. This is causing us a little bit of problems in terms of upstairs is patients have got to be able to get upstairs. So we are going to have to do a smaller group downstairs, but I'm wanting to get the maximum number in that smaller group to make it cost efficient. So they then come in, they see our healthcare. Our healthcare knows this information. She knows how to explain how to give the injection, explains that they've got to sign up for the wraparound service. She refers them to wraparound service. All the patients get weighed, and if they want to proceed, they then sign up. We haven't at that point yet had a patient say no because they've got that far on the journey. Then they come in, or they can do it over the phone, for a 20-minute consultation with our nurse prescriber. She does a lot of our diabetic meds, so she knows how to alter people's diabetic meds, because that's the really important thing when you're starting on Mounjaro. She then goes through the side effects, checks their family history, and if they're on either gliclazide or insulin, make sure they have a working BM machine, and drops their requirements of insulin and gliclazide appropriately, and then sends them on their way. If a patient is on gliclazide or another sulfonylurea or insulin, she will then book in a month a 10-minute phone call review, because she's going to have to keep down titrating those hypoglycemic meds. If they're not on a hypoglycemic med, then we've developed an Accurix questionnaire, which I'll show you, which our nurse prescriber then triages. If there are no issues, she issues the med. If there are concerns, she then does have a 10-minute consultation. But these triage slots, she just gets 5 minutes to do them, with the aim that a lot of them won't have significant issues, and therefore it's just time efficient. So this is the leaflet that we have designed that all our patients get when they come in. So they get given a printed version, so the serious and the common side effects, tips for management, and how to take it. So all of our patients get this. It's also on our website. So in the Accurix questionnaire, there is a tiny URL to send them to this in case they have lost it. So this is the Accurix questionnaire. So it's asking for an up-to-date weight. It says here, having read the leaflet, have you any serious side effects? Again, there's a tiny URL. Yes or no. And then in that case, obviously they've been told in the first place, if they have a serious side effect, then they need to stop it and let us know. But if they have at this point, then that would automatically trigger a consultation. And then the third question, on the common side effects, are they bothering them? Do you want to discuss this? And then the final question, would you like to increase your dose? Yes, please, and issue it. No, I'd like to send the same dose. No, I'm not interested in going up any further, but that they would like to speak to us, or they're on the max dose, and so please now add it to my repeat prescription. So that is our pathway that we do with our patients. We find that it works well. The group consults at the beginning, the patients like, because actually they get to meet other people, they get to go on this journey together. As I said, the slight issue is obviously around rooms in group sizes and trying to get as many that you safely can get in a room at any one time. So in terms of some of the challenges that I've encountered, patients wanting to start yesterday and being quite threatening in how much weight they could have lost if I'd started them on it yesterday. And it's just resetting expectations and saying, we will be in touch. We're trying to do this in a safe and controlled manner. By doing the group consultations and having those 10 patients, then we're starting 10 off at a time, which isn't causing too much significance into rota planning and demand within our nurse prescribers' appointments. Our plan was we did one in June, we'll do another in September, probably another in November, December. And if we need, we can do a further one into the new year. But it's staggering. It's starting with those with the highest comorbidity and working down the list. In terms of getting started, I just encourage you to think about your SOP, what works best for your patients. And I would encourage those in your practice who are skilled at diabetic meds to be the ones to take the lead here, because they are the ones, the patients who are most difficult to titrate are the ones that you've got to detitrate, down titrate their insulin and sulfonylureas. So that's just a whistle-stop tour about how we've decided to deliver the obesity part of QOF to do with medication. And I hope that is helpful. If anyone wants to get in touch, I'm happy to share the Accurix questionnaire and our leaflets for you guys to use in your practices. Thank you very much.